Now it's my pleasure to introduce Dr. Rashbaum, who is the Chief of Stroke Rehabilitation at Rusk. And he cares for adult stroke people who come in for inpatient care and outpatient care. Rusk's stroke rehabilitation program is recognized as one of the nation's leaders in this area. In 2006, it became one of the first programs nationwide to receive designation by the Commission on Accreditation of Rehabilitation Facilities. Dr. Rashbaum also cares for adults with general outpatient rehabilitation needs, including chronic pain and musculoskeletal disorders. In particular, all right, this is not, he has an expertise, sorry, just page disorientation there, in diagnosing and treating, you're gonna think I'm having a stroke by the end of this presentation. Diagnosing and treating psychosomatic pain disorders in the same manner as Dr. John Sarno, one of his mentors when undergoing residency training at Rusk in the early 1990s. Dr. Rashbaum has served as chair of the study guide committee of the American Academy of Physical Medicine and Rehabilitation, a position that placed him at the cutting edge of all aspects of rehabilitation medicine. And Dr. Rashbaum was selected as a top doctor in the 16th edition of Castle Connolly's Top Doctors New York Metro Area in 2013. It's a pleasure to welcome you here.
Thank you very much, Ms. Harder. And again, I echo Dr. Siller. That was about as good an intro as I've ever received. And good afternoon to everybody. And I see so many familiar faces, and thank you for showing up, as well as those who are new to us. So, also just wanted to follow up from Dr. Siller, particularly for the folks who are not NYU family members here, is that what are radiologists doing taking care of patients with stroke? I thought radiologists just sat in dark rooms and looked at films, but certainly there's a whole subspecialty in radiology, interventional radiology, and in Dr. Siller's team, interventional neuroradiology, that can do all sorts of amazing things, not only in a diagnostic way, but in this case in a therapeutic way. So I just wanted to add a grain to Dr. Siller's wisdom. So in the time we have today, I wanted to talk a little bit about Rusk. Rusk is a very near and dear thing to me and many people, I think, in the room and even outside the room. And from a historical standpoint, the Rusk Institute was established in the late 1940s and I think was among, if not the first building established on our present footprint here by First Avenue. Rusk Rehabilitation is continuing to grow under Dr. Flanagan, our chair's leadership, and it's a very exciting time for the Rusk Institute. But today our task at hand is about stroke rehabilitation, so let's get right into it. Mirroring from what Dr. Siller had mentioned a few moments ago, stroke is a serious thing. It's the leading cause of adult disability, at least in our country. But also, fortunately, as Dr. Siller said, many people, due to a whole variety of people, both professional and non-professionals' efforts, survive stroke. And there are over 4 million people who are stroke survivors with disabilities, disablements, the newer term in our country. However, still there is much work to be done. Those numbers coming from the American Academy of Physical Medicine and Rehab indicate that as many as a quarter to a half of these survivors are either totally dependent in their overall function or at least partially dependent in their overall function. So fortunately, I guess it sounds as if 50 to 75% of them are quite functional and maybe fully functional, but not all are. And in terms of costs, we're talking about a multi-billion-dollar situation in terms of care, costs, and in lost earnings. What are some of the key elements of stroke rehabilitation? As Dr. Siller alluded to, prevention. Prevention is key whenever possible. Also treatment, largely with Dr. Siller and his team of professionals. And then when you start getting more into the rehabilitation phase of things, compensation. We mean compensation not in terms of time or money, but compensating for neurological impairments, weaknesses, difficulties with speech, difficulties with sensation, and overall disabilities that may have incurred because of the stroke. Maintenance, maintaining people's overall health and hopefully improving it, but also maintaining their gains in function that have presumably occurred through the course of their rehabilitation. And then, very, very importantly, looking at these people always, but particularly not only as patients, but as people, as human beings, reintegrating these survivors of stroke back into society as much as humanly possible. As alluded to, though, what are our goals or some of our goals of stroke rehabilitation? We want to restore these people to maximum mobilization, help them regain functional independence and confidence, provide measures to prevent falls and to ensure safety. Remember, back in math, a double negative is a positive. So if we are preventing negative things from happening, that in and of itself is a positive thing. Education, 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 including what this is all about today, and lots of people's efforts here who should be thanked. Educating patients, families, caregivers, communities about secondary prevention of stroke and primary prevention of stroke, as we talked about with the screenings and what have you today, and to facilitate psychosocial adjustment. Dr. Siller had a slide showing all sorts of people on a team, and rehabilitation maybe cornered the market or certainly helped to innovate the team concept in healthcare. And there are at least a couple of teams that need to be identified and acknowledged. I call this the team of physicians, and which include in no particular order physiatrists, doctors such as myself, Dr. Flanagan, many others who are in the field of physical medicine and rehab. A family physician and or an internist is so important. In fact, when patients leave the inpatient setting at Rusk, or occasionally I try to remind them in the office setting, is I will say something such as, if you don't remember anything I say, if you remember only one thing, even with all the education that I've tried to impart to patients, I will say, you must follow up with your internist or family physician or both as soon as possible when you leave here, because she or he is going to be your medical quarterback, and it's just so imperative they do that. Stroke is largely an older person's disease, but certainly young people are not immune to it, so geriatricians are often very helpful in terms of even preventing polypharmacy, which sometimes can be detrimental to patients in all sorts of care settings. Neurologists, of course, psychiatrists, cardiologists, and neurosurgeons, and others who aren't necessarily on the slide are part of a large medical team. Then, of course, there's another very large and equally, if not more important team, the team of other members of the team, including the rehabilitation nurses, psychologists, occupational therapists, recreational therapists, physical therapists, speech-language pathologists, otherwise known as speech therapists, perhaps, social workers, and nutritionists. I can go into what each of these professionals do, but I want to go on to the next slide and perhaps answer any questions if any arise. Rehabilitation care settings. Rehabilitation occurs in a whole continuum of care, not exactly when Dr. Siller and his team get the patients. That's at the very beginning in the emergency setting and in the critical treatment setting and diagnostic setting, but pretty soon thereafter. It's usually the rule rather than the exception that Dr. Siller and his team is calling in the rehab team within 24 hours of the patient even sustaining a brain attack or a stroke. So rehab is occurring sooner and sooner and quicker in intensive care unit settings, in emergency rooms not rarely, and certainly in regular hospital wards and floors and rooms. And this involves virtually, if not all, of the members of the rehab team, people from nursing, physical, occupational, speech therapy, social work, psychology, et cetera, et cetera. Then for some of the patients who require stroke, often it's those who unfortunately are still so impaired medically, neurologically, and also disabled, or people otherwise, they may need to come to an acute inpatient rehabilitation facility such as the Rusk Institute, which is in our setting on 17th Street for the most part, for now, of course, all in Manhattan at 2nd Avenue. And this is a specialized and a highly achieved and specialized stroke rehabilitation, but also other rehabilitation program that has all of these team members and more, and provides a level of care second to none in terms of medical care, nursing care, and all sorts of rehabilitative care, where patients may stay for a handful of days, rarely but often for several days, and sometimes even for a few weeks or so. Sometimes patients either directly from the acute care hospital, also sometimes occasionally from the acute inpatient rehab center, such as at Rusk Institute, may need to go for some more inpatient rehab in another type of setting, which we call a subacute rehab setting. Other patients can go home either from the medical hospital, acute care, and hopefully whenever possible from acute inpatient rehab. And most eventually who have to go to subacute rehab can eventually get home. But does the rehabilitation for these patients with stroke end there? Absolutely not. Rehabilitation will continue, often for the rest of their life in certain shapes and forms, and we want to have these patients re-seen and re-evaluated and re-cared for at an acute outpatient rehab center, just an outpatient rehab center that Rusk Institute has at our ambulatory care center, but could be through many other centers and other programs around the country and beyond. And I think that's my last slide. So I think that also, in the interest of time, wanted to give other speaker a chance to speak. Thank you very much for listening.